Welcome to the deep dive. Today, we're zeroing in on something really critical in vascular health.
Yeah, how we actually figure out if enough blood is getting to the tissues in your lower limbs.
Right, especially when you're dealing with things like peripheral arterial occlusive disease, PAD, or, the more serious CLTI, critical limb-threatening ischemia.
Exactly. And, we have standard clinical exams,
Yeah.
tests like the Ankle Brachial Index, the ABI.
Sure, everyone knows ABI.
But as our sources today point out, these are chapters from Rutherford's Vascular Surgery. The 10th edition of those tests, well, they don't always give the full story.
Especially for the really small vessels, right?
Right.
The microvasculature.
Precisely. And that's vital for things like rest pain or getting wounds to heal. Big issue if you also have diabetes or kidney problems.
So our mission today, for you listening, is to really understand the different ways we can assess this micro-level flow, going beyond just, checking if the big pipes are open.
That's a good way to put it. It's like knowing the highway's clear, but not the local roads getting to the houses. We're diving into techniques that look at whether the tissue itself is getting what it needs.
And the sources mention some fascinating methods, some invasive, some not, some maybe not quite mainstream yet.
Definitely. It's becoming clear that just opening a large artery doesn't automatically guarantee less pain or a healed wound for you.
Ah, okay. So measuring local tissue perfusion might actually be a better predictor of whether, say, a revascularization procedure will really make a difference.
That's the idea. It could be a game changer for predicting success. So yeah, let's get into these techniques. Maybe start with the more invasive ones.
Sounds good. What's first on the list?
Okay, first up is something called two-dimensional perfusion angiography. You probably know standard digital subtraction angiography, DSA.
Yeah, the X-ray movies of blood vessels with contrast dye.
Right. Well, this takes those standard DSA images
Yeah.
and uses some clever software for post-processing. It basically creates a sort of time-lapse movie showing how the contrast moves through the microcirculation, the really tiny vessels. It generates these color-coded images based on changes in pixel density over time.
So it's highlighting how quickly the contrast gets into and out of specific small areas, like in the foot.
Exactly. You select a region of interest, say on the foot, and the software can calculate parameters representing that contrast inflow and outflow in the microcirculation.
And has this been tested? Does it line up with things like ABI or toe pressure?
Yeah, researchers have looked into that, correlating it with ABI, toe brachial index, skin perfusion pressure, trying to see if this detailed microview adds valuable info.
But I sense a but coming. What are the
Right.
catches?
Well, the big one is it relies on DSA, which, isn't something you just do for a regular checkup. It's invasive, involves radiation and contrast.
Right, not for routine monitoring.
Plus, motion artifacts can be an issue if you move even slightly. It can mess up the images maybe up to 10% of the time. And you need really standardized protocols for it to be reliable. Honestly, its overall validity and accuracy still being properly figured out. There's actually a study, Repeat, looking into its reliability right now.
So, interesting idea, detailed view, but practical limitations for everyday use. Got it. What's next in the invasive category?
Okay, sticking with contrast and imaging, there's computed tomography perfusion imaging, CT perfusion.
So, using a CT scanner, how does that work for perfusion?
It combines standard CT angiography, which gives you the detailed pictures of the larger vessels, with CT perfusion imaging.
What's the perfusion part add?
After injecting contrast, instead of just static images, the system calculates changes in tissue perfusion parameters over time. It tracks how the contrast moves through the tissue.
Ah, so it's dynamic. You get data on flow, volume, that kind of thing.
Exactly. It generates what are called time attenuation curves, TDCs, showing how contrast concentration changes. From those, you can extract quantitative numbers for things like blood flow, blood volume in the tissue.
And has this shown promise? Can it detect changes, say, after treatment?
Yeah, studies show it's feasible and reproducible for seeing changes before and after endovascular treatment, EVT. One study even found differences in blood volume between different ABI groups.
Oh, interesting. So it might pick up things ABI misses.
Potentially, yeah. And the advantages are clear. You get both numbers, quantitative data, and you can visually assess perfusion patterns, qualitative data. Plus, CT generally has high spatial resolution. It's widely available.
And probably quicker and cheaper than MRI, I'd guess.
Often, yes. But, like the angiography, it's susceptible to motion artifacts. And the big one, ionizing radiation.
Right. So again, maybe not ideal if you need lots of repeat scans for follow-up.
Precisely. Useful, but that radiation dose is a factor.
Okay, moving on. What about ultrasound? I know we use Doppler ultrasound a lot, but can it see the microcirculation?
Not standard ultrasound typically,
Mm-hmm.
but there's contrast-enhanced ultrasound, CEUS.
Contrast for ultrasound. How does that work?
It uses these tiny microbubbles, way smaller than red blood cells, injected intravenously.
Okay.
These bubbles circulate everywhere, including the microvessels. When the ultrasound waves hit them, they oscillate and send back a much, much stronger signal than blood alone.
So they light up the microflow on the ultrasound screen.
Basically, yes. It lets you visualize microvascular blood flow, especially in skeletal muscles, much more clearly.
And what can you measure with that?
Things like the time it takes for the bubbles to reach peak intensity in an area, time to peak, or TTP and the peak intensity itself, reflecting perfusion volume.
Has that shown value for PAD?
Well, one meta-analysis suggested TTP could differentiate PTD patients from healthy folks. But interestingly, it didn't correlate well with ABI in that analysis.
Okay.
More recent studies show differences maybe after exercise or if you temporarily restrict blood flow. One study even showed changes right after revascularization. But those changes didn't necessarily stick around long-term in that particular study.
So maybe good for seeing an immediate effect, but less so for long-term tracking.
Possibly.
Yeah.
And the limitations, well, it's invasive needs, that IV injection. It's very operator dependent. The skill of the person doing the scan matters a lot.
Right.
Protocols aren't standardized across studies. And like we said, it doesn't always match up neatly with things like ABI. So it's another tool, but still evolving in terms of its role.
Okay, that makes sense. Now, MRI, magnetic resonance perfusion imaging. The sources list a few acronyms here. ASL, BOLD, DCE, AVIM. That sounds complicated.
It's quite sophisticated. These are all different ways MRI can measure perfusion-related aspects in skeletal muscle.
Can you give us a quick version of each?
Sure. ASL, arterial spin ladling, it magnetically tags water in the arterial blood and tracks it moving into the tissue. No contrast needed.
Okay, neat.
BOLD, blood oxygenation level dependent, uses the fact that oxygenated and deoxygenated blood have different magnetic properties. Again, no contrast.
Right, like functional MRI in the brain often uses BOLD.
Exactly. Then there's DCE, dynamic contrast enhanced. This one does use a contrast agent, and it watches how that agent enters and leaves the tissue over time.
Okay.
And IVIM, intravoxel incoherent motion, looks at the random microscopic motion of water within tissue, which is related to capillary flow. Also no contrast.
So 3 out of 4 don't need contrast, which is a definite plus for some patients.
Absolutely. A big advantage.
And have these MRI methods shown they can detect changes maybe after treatment?
Yes. Studies using ASL and DCE have shown increases in perfusion parameters after successful EVT. There's also research comparing these techniques directly. One study suggested BOLD might be the most reliable for measuring resting perfusion in PT patients.
So lots of potential with MRI offering different angles on perfusion, but I'm guessing it's not without its drawbacks.
You guessed right. The main ones are cost MRI is expensive.
Yeah.
Claustrophobia can be a real issue for some people.
Yeah, a long time in a tube.
And the scans themselves can take quite a while compared to, say, CT or ultrasound.
Right. So powerful, detailed, but resource intensive.
That sums it up pretty well.
Okay, let's switch gears slightly. Near-infrared fluorescence imaging with indocyanine green, NIRF-ICG. What's the story here?
Okay, so this involves injecting a dye, indocyanine green, or ICG, intravenously. This dye fluoresces. It glows when hit with near-infrared light.
And you capture that glow with a special camera?
Exactly. You track the fluorescence intensity over time. This lets you visualize blood perfusion in the skin. You can see different phases, the arterial blood coming in, capillary perfusion, then venous outflow.
Like watching the dye move through the skin's vessels. How deep does it see?
That's a key point. The penetration depth is pretty limited, maybe up to 5 millimeters. One specific system mentioned is the SPY technology, with about that depth.
So mainly skin perfusion, not deeper muscle.
Correct. Primarily skin.
Has it proven useful diagnostically for hepatic or predicting outcomes?
Studies have reported some diagnostic sensitivity and specificity for PA. It's also been used to see if skin perfusion improves after revascularization. But one study couldn't replicate its ability to predict long-term outcomes, like amputation. So the jury's still out a bit on its prognostic value.
And limitations, besides the shallow depth.
Well, that limited penetration is the main one.
Yeah.
Also, there's variability in the imaging devices and protocols used in different studies, making comparisons tricky.
Okay. One more invasive technique mentioned is SPECT, TCT. Single photon emission computed tomography, combining nuclear medicine and CT.
Yes, exactly. You inject a small amount of a radioactive tracer. The SPECT part detects the gamma rays emitted by this tracer, and where it concentrates indicates blood flow at the tissue level.
And the CT part.
The CT scan is done at the same time to provide the anatomical map. So you overlay the functional blood flow map from SPECT onto the detailed anatomical structure from CT.
Giving you function and structure together for the lower limb and foot.
Right.
What's the experience with this in PADI CLTI? Is it used much?
The sources say reported experience is still a bit scarce compared to others, but studies have shown good reproducibility.
Any findings on predicting outcomes?
Interestingly, yes. One study found that low perfusion, measured by SPECT-TCT, was an independent predictor of major adverse events later on.
That could be significant prognostically.
It could, but again, limitations. It's invasive, tracer injection, it's costly, and it involves ionizing radiation from both the tracer and the CT.
Right. Okay, that covers the invasive methods. A lot of interesting technology there, but all with significant hurdles like invasiveness, cost, or radiation.
Definitely. Which brings us nicely to the non-invasive techniques. These are often preferable if they can give us the information we need.
Makes sense. Let's start with hyperspectral imaging, HSI. What is that?
HSI uses visible light spectroscopy. Basically, it shines light onto the skin and analyzes the full spectrum of light reflected back.
And how does that tell you about perfusion?
Because oxygenated hemoglobin, OxyHB, and deoxygenated hemoglobin, deoxyHB, absorb and reflect light differently across the spectrum. By analyzing that reflected spectrum, HSI can calculate the relative amounts of each, giving you a measure of skin tissue oxygenation.
Without touching the patient. And it produces images.
Yes, contact-free. And it typically generates color-coded images where different colors represent different oxygenation levels.
Has HSI shown differences in PAD patients? Or predictive value?
Studies do show lower oxygenation in PA patients compared to controls. And really promisingly, some research suggests it might help predict the healing of diabetic foot ulcers.
Wow, that would be huge. Diabetes and foot ulcers are such a massive problem.
Absolutely. And the potential benefits of HSI are appealing. It's fast, often uses handheld cameras, contact-free. You could even imagine it being used for home monitoring eventually.
But limitations. There always seem to be limitations.
The main one here is penetration depth. It's minimal, maybe just 1 to 2 millimeters. So it's really only looking at the very surface of the skin.
Okay, so surface oxygenation.
Right. And also, different studies have used different camera systems and analysis methods, so comparing results isn't always straightforward.
Got it. Next up, lasers. Laser Doppler Perfusion Imaging, LDPI, and laser speckle contrast imaging, LSCI. What's the difference?
Both use laser light shown onto the skin to look at microcirculation. They both work by detecting changes caused by moving red blood cells.
How do they detect those changes differently?
LDPI measures the Doppler shift, the change in frequency of the laser light scattered back by moving red blood cells. That shift is proportional to their speed, so it measures flow.
Okay. And LSCI?
LSCI looks at the speckle pattern created when the laser light scatters. Moving blood cells make this pattern fluctuate or blur over time. LSCI analyzes these fluctuations to measure microcirculation or flow speed. They differ in exactly how they acquire and process the data.
Has LSCI shown promise for anything specific?
Interestingly, yes. One study showed it had good sensitivity and specificity for predicting the healing of venous ulcers.
Okay, venous ulcers. What about for PAD?
Studies using both LDPI and LSCI have shown significant differences between PD patients and healthy controls. And LSCI values have been shown to increase after revascularization.
So potentially useful for diagnosis and monitoring treatment?
Seems so. The benefits are they're non-invasive and quick. They're sensitive to motion artifacts, tricky with legs sometimes. Penetration depth is low, mainly superficial flow. And things like skin temperature or certain medications can affect the readings.
Right, factors you need to control or account for. Okay, next. Microlight guide spectrophotometry, or O2C. Oxygen to see. Catchy.
It is. This one combines two techniques using a probe with optical fibers placed on the skin. It uses laser Doppler, like LDPI, to measure flow.
Okay.
And it also uses spectrophotometry, analyzing the reflected light spectrum, like HSI, to measure oxygen saturation, SO2, based on oxyHB and deoxyHB.
Ah, so you get flow and oxygenation from the same probe.
Exactly, a combined measurement. The penetration depth varies a bit depending on the probe, maybe 2 to 8 millimeters.
Still relatively superficial, but maybe a bit deeper than HSI or the laser techniques.
Generally, yes.
Has OTC shown clinical utility?
It's shown potential for predicting low toe blood pressures.
Yeah.
And studies have used it to assess treatment results. One found significant improvements in both mean SO2 and flow after EVT.
Sounds useful. Limitations?
Still that relatively low and variable penetration depth. And the probe measures a pretty small area, so it's a very localized assessment. You might need multiple measurements.
Right, might not represent the whole foot or limb. Okay, near-infrared spectroscopy, NIRS. We mentioned this briefly with MRI, but how is it used non-invasively?
As a non-invasive technique, NIRS involves placing sensors on the skin that emit and detect red and near-infrared light. This light penetrates deeper than visible light.
How deep?
Roughly 15 to 20 millimeters, so about 1.5 to 2 centimeters. This allows it to measure oxygenation within the underlying muscle tissue, not just the skin.
Okay, that's a key difference getting into the muscle. What does it measure specifically?
It measures tissue oxygen saturation, usually called STOO2 or sometimes RSO2, based on how much light is absorbed by oxy-HB and deoxy-HB in that tissue volume.
And how has NIRS been used in PAD research?
Quite a bit. It's been used to assess muscle oxygen changes during and after exercise in PAD patients, to differentiate PAD patients from controls based on their SOTO2 levels, and also to evaluate changes after EVT.
Any specific findings after treatment?
One study found that means SOO2 in the calf muscle increased 4 weeks after successful revascularization.
So it can track physiological improvements in the muscle. Advantages.
It's pretty easy to apply sensors to different spots on the leg or foot.
Disadvantages.
Well, there are many different commercial NRS systems out there, and they don't all use the same methods or algorithms, making study comparisons difficult.
Okay, consistency issues.
Also, SOO2 reflects the balance between oxygen delivery and oxygen consumption by the muscle. This can make interpreting changes, especially during exercise when consumption goes way up, a bit complex.
Right, low STO2 could be poor delivery or just high usage.
Exactly.
Yeah.
And there's a potential issue in diabetic patients where readings might be falsely low due to high metabolic demand, even if delivery isn't great.
Tricky interpretation sometimes. Okay, almost there. Skin perfusion pressure, SPP. How is this measured?
SPP uses a small cuff, often on a toe or the foot, and a laser Doppler probe placed under the cuff. You inflate the cuff to stop blood flow completely. Then you slowly deflate it. The SPP is the pressure reading on the cuff. At the exact moment, the laser Doppler detects blood flow returning to the skin microvessels underneath.
So it's the pressure needed to restore microcirculatory flow. Is there a target value?
A value of 30 mmHg is often cited as a threshold. Below that, wound healing might be impaired. Above it, generally, better prospects.
And does it correlate with outcomes? Does it change after treatment?
Yes. Studies show STP often increases after successful revascularization, and higher post-procedural FPP values have been linked to better wound healing and amputation-free survival.
Sounds clinically relevant. What are the downsides?
Leg position during the test can affect the reading. Motion can cause artifacts, and sometimes placing the cuff, especially on swollen or painful feet, can be difficult or uncomfortable.
Okay, now a real old-timer in some ways. Transcutaneous partial pressure of oxygen, TCPO2.
Indeed, this one's been around a while. It measures the amount of oxygen gas, the partial pressure in mmHg, that diffuses from the skin capillaries out to a heated electrode placed on the skin surface.
Why is the electrode heated?
Heating it, usually to about 44 degrees Celsius, maximizes capillary blood flow locally and helps oxygen diffuse out more readily, giving a more representative reading of delivery potential.
Does it take long to get a reading?
Yes, that's one drawback. It needs time to equilibrate, often 15-20 minutes per measurement site.
And what's its main clinical use?
It's been heavily investigated for predicting wound healing potential and helping determine the appropriate level for amputation, if needed. It's even included in some CLTI guidelines.
Is there a normal range or critical value?
Healthy foot TCPO2 is typically at least 55 mmHg. Meta-analyses suggest values below 40 mmHg are linked to higher risk of wound problems or poor healing. Some studies link specific low values to amputation risk.
But is it foolproof?
No. One study mentioned in the sources found it didn't add much predictive value beyond just good clinical judgment.
Interesting. And other limitations besides the time it takes?
It can be operator dependent. The measurement area is small, very localized.
Yeah.
And things like edema, skin thickness, hair, or even infection increasing local oxygen consumption can throw off the readings.
Right. Lots of potential confounders. Okay, finally, thermal imaging. Infrared cameras.
Yep. Using an infrared camera to measure skin surface temperature based on the heat radiation emitted.
And the link to perfusion is?
The idea is that areas with better blood flow are warmer because the blood delivers heat. Poorly perfused areas tend to be cooler. Studies show good reliability between different cameras.
Has this shown correlation with vascular issues?
Yes. One study found a 2 degrees Celsius drop in temperature was highly sensitive and specific for predicting graft failure after bypass surgery.
Wow, that's quite specific.
Another found good agreement between a temperature ratio comparing foot to hand temp and the standard ABI. And others have seen foot temperature increase after revascularization.
Seems simple and non-invasive. Limitations.
The big one is that many things affect skin temperature besides perfusion, recent activity, room temperature, infection, inflammation.
Right, lots of variables.
And the exact link between these temperature ratings and long-term clinical outcomes like wound healing or amputation isn't fully nailed down yet.
Okay, so that's a comprehensive tour of the techniques. It really highlights a key point, doesn't it? Current standard assessments mostly look at the big vessels.
Right, the macrovasculature. But what you, the patient, experience pain, wound healing, ability to walk that seems much more tied to the microvasculature, especially if you have diabetes or other issues affecting those small vessels.
And it's clear there's this growing arsenal of techniques trying to measure that micro-level perfusion. But our sources also point out a lack of definitive large-scale studies.
Exactly. Not enough big meta-analyses or randomized controlled trials comparing these head-to-head, especially for predicting long-term outcomes or guiding therapy reliably.
And lots of variation between studies, different protocols, different devices.
Yes, heterogeneity is a big issue. Plus, there's no single perfect gold standard for tissue perfusion to compare everything against. That makes it really hard to know which technique is truly the most accurate or useful overall. Some are being validated against outcomes like healing, which helps.
Are there even newer things on the horizon?
The sources mention a few emerging techniques like optoacoustic imaging, which looks promising elsewhere but is very early days for peripheral perfusion. Things like measuring mitochondrial oxygen uptake or using special PD scans are really still research tools.
So the dream technique, this sort of holy grail, would need to tick a lot of boxes, wouldn't it?
Absolutely. You'd want something non-invasive, cheap, fast, reliable, easy to use.
And usable everywhere. Initial diagnosis, during a procedure maybe, for predicting healing, monitoring progress in hospital and at home.
That's the ultimate wish list. Something that accurately tells us if a limb can be saved, guides treatment, predicts healing, and monitors long-term, both in clinic and maybe even remotely.
So wrapping this up, this deep dive into Rutherford's really shows this wide, fascinating spectrum of methods being explored for tissue perfusion in P8 and CLTI.
Yeah, invasive, non-invasive, each with its own profile of strengths and weaknesses, accuracy, practicality, cost, invasiveness, clinical applicability.
And hopefully for you listening, understanding these gives a much more nuanced view of vascular health beyond just ABI or seeing if an artery is blocked.
It really emphasizes how crucial that microcirculation is for how you actually feel and function.
Which leads us to a final thought for you to chew on. With all this complexity and ongoing research, how do you think these different techniques might eventually fit together? Could we see combinations being used for a really personalized assessment?
Could a mix of, say, a non-invasive screening tool plus a more detailed imaging method give us the best picture?
And how might that kind of comprehensive view change treatment decisions and ultimately improve things for people living with PA and CLTI? Which of these tools we discussed seems most promising to you for the future, and why?
Lots to think about there.
Definitely. Thanks for joining us for this deep dive.